laborers and very little unemployment. Farm employment now. Large farm owner, only white, average farm owners size, small, and a few African Americans owning small farm, and then sharecropper and laborers primarily, where African Americans men earn a living in terms of farm employment. What to do with that? The prevalence of CHD manifestations were comparable in black men and low social status white men. That was the one striking observation, that there was one stratum in all these comparisons where African American men and white men were comparable in terms of their odds if you or the prevalence of coronary heart disease. And that was low social class and all African Americans who sort of made it into the sharecropper laborers. They stratified this, they analyzed it according to all the risk factors they had measured. And that contrast, that observation persisted at all levels of these CHD risk factors. So they concluded that the differences in occupation suggest a further risk factor. CHD rates were comparable in black and white men when both were sharecroppers. And they thought, what may be the explanation for this? Physical activity was considered to be, again, a prominent player here, as a possibility. And yet interpretation of these data were, of course, had some shortcomings and limitations, such as differential mortality, where they observing the more vigorous survivors among those with highest risk. So it was a concern with cross-sectional design. Reverse causation in terms of what's driving the dynamic of the process. So a proposal was then made to follow up and re-examine, in other words, build up all those free of coronary heart disease that had been originally examined. So basically from cross-sectional survey and make that a cohort study. It was funded, and they promptly proceeded to recontact and trace all examinees through visits to their household, relatives, contacts, trying to catch and contact the ones who moved out of the country. It was a very little country, it was very little mobility. Health events were ascertained in contacting them, documentation assembled for central review and classification of events. In other words, they did what you would do for a cohort study. The decedents were identified, autopsy reports were assembled. In those days, autopsies were used to be performed. Health status of those not re-examined was ascertained and they were ascertained by phone. In other words, protect themselves against bias. And as I mentioned before, stroke was introduced as a outcome, as a study outcome, and treated as a competing risk in assessments of coronary heart disease. They did some interesting analyses based on the data available about misclassification, because the concern in this study question was, of course, underdiagnosing African Americans, overdiagnosing perhaps whites. So they did a series of interesting exercises that are published, and the reference is not there, but in this, at the end of the slides deck is URL that has all these papers listed. And from there, the cohort re-examination took place 67, 69, included pretty much the same battery as applied at the baseline, plus a few additional interviews and tests. 2 examiners, in my opinion, unfortunately, they were in these, but they were standardized. They tried to standardize each other. Factors included socioeconomic indicators, blood pressure, cholesterol levels, cigarette smoking, body weight, hematocrit, and 12-lead ECG. Overall rate of follow-up, 99%, and 90% of the cohort was re-examined. Again, I don't know what to do with that, other than cry. Health events were ascertained by phone for this roughly 8% of folks who didn't make it to the exam. Remarkably well. And by the way, many people report in papers and anecdotal. Much of this was due to the small size of the county, the closeness of people, but also the community outreach from Curtis Haynes' office. He was a doctor who suggested to all of them that this was important for the health. Labored hard to bring them all out. And distinctive features, how would you want to remember Evans County study? The prospective cohort composed of the entire population of the county older than 40 years of age, and half the population aged between 15 and 39 years. So it's a whole study. It's the only epidemiologic study at the time to study incidence of CHD in blacks and whites, and one of only 2 epidemiologic studies that studied entire communities. And the other one was the counties, as I mentioned. They had a small community close to Ann Arbor. That study was larger, had 9,000 people, so also had very good response rates and detention rates. But the length of follow-up was comparable, but the variables measured was a little bit less dense than in Michigan in the country. It examined, perhaps for the first time, deliberately the role of social, behavioral, economic, and biologic factors and the interplay. In those days, stratification was the only tool. Effect modification was not something that investigators could throw at their data or could conceptualize, had conceptualized very well. Intertemporal change. So what were the main findings from the study, at least the ones that stand out today? The factors associated with increased risk of CHD did so comparable for African Americans. So there were no risk factors for African American risk factors. These traits, behaviors, and phenotypes were mentioned as risk factors. Performed equally for whites and blacks. And they were examined individually as well as in combination using some new tools that are called multivariate analysis. Risk factors acted comparably across, not only across race, but also social status differences. Changes in occupation behaviors and risk factors were seen after several years to a remarkable degree. The young residents of that county very quickly were changing lifestyle habits, they were adopting new lifestyle practices, and were finding jobs that were outside of farming, outside of cutting trees. And remarkably, together with that, changes in their risk factors were occurring. Cholesterol at the top, blood pressure at the top. So now whites were catching up with African American residents of that county. The CHD incidence, however, remained remarkably high for white residents and for black residents of America. Again, the only social grouping of white residents that equally low CHD incidence, not just prevalence, but incidence, were white sharecroppers, and this was attributed to the higher rates of physical activity. So, I'll stop there for a moment. That's in a nutshell. I have to ask for forgiveness for many good papers written from many county data, so glossed over. But that is what this study contributed, as I said, a deliberate attempt to go beyond the biologic risk factors that were being looked at. Joining other studies like the Western Collaborative and others that were starting to look at behavior and social factors, the opinion of the investigators while they were writing up this finding, the future insights in terms of our risk of coronary heart disease, but susceptibility to coronary heart disease, it's going to come from our social environment and psychosocial environment that we now need to examine beyond cholesterol, blood pressure, and the like. Any comments, any questions? Vic, you wish to add anything? Alice?
No, I think it's important. You mentioned it, but I think it's just hard to imagine with today's technology and data manipulation that we can do what an undertaking this was. I mean, you held up the cards, but that was about 3 stages after collecting the data from the patients, probably by pencil on paper forms. I never went down there, but we entered a lot of it on these cards once it got here. And I think the other really unique thing that you pointed out several times was the commitment on the part of people in the epidemiology department here to tackle these factors, the social and economic factors that were facing this population, which, in my sense, really wasn't done before. And I think that tradition in this department has continued for decades. So it's nice to see that again. But thanks.
Thank you. Very good. In the interest of time, I'll continue. Some questions perhaps sort of for discussion with you and after I find each other. Let's think about something like 5 decades after Orange County, and one thing that struck me right away is that we still use this term race to group people, and as a researcher, we still use it as a proxy for what we don't know exactly, but we have. It's sort of a convenient shortcut to so many factors that we have failed to conceptualize and operationalize very well. So there it is. Still, when we started out looking and contrasting people according to the color of their skin and how they live, and how far have we come from that position? I should note, and which is pretty obvious to everybody, of course, that while Orange County showed us a remarkable deficit of chronic heart disease among African American men and white men that were working, physically exerting themselves very hard, in the following decades, in the country as a whole, there was a considerable excess burden of chronic heart disease by race, and cultural and economic stratification. So in contrast to what was observed in Orange County in the 60s, African American men and women experienced remarkable excess mortality and morbidity from cardiovascular diseases since in the last 3 or 4 decades. This is just now converging in terms of chronic heart disease mortality. Stroke mortality has moved faster, and so forth. Studies such as what Dr. Rosamond does in terms of community-wide surveillance is showing us this pattern. We still haven't reached the point where, say, African Americans have a lower mortality than whites or something. There still is an exit. And that was very large 3-4 decades ago, and is now slowly converging and coming down. The question is it continuing to come down? You have heard these insights from Wayne. Risk factors for CHD, stroke, and the sequelae are now, I would say, very well understood. Those were the days when people started out a study to really know about additional risk factors. We know that we can predict stroke very well. We can predict chronic disease very well. I put there somewhat conservative estimate, 75% of the variability in chronic heart disease can be accounted for by what we call risk factors. More than that, I'm sure, for stroke. Still a very complex condition, multi-causal. These are syndromes, they're hard to classify now, but we can predict. So it's no longer the case. The paradigm is completely different. None of us would venture into a new study to find any risk factors, something which we can account very well. Where are the concerns? Well, we have given biologic traits primacy in what we learned about risk factors and in taking them into practice. If you think of the famous risk scores that clinical practitioners use, Baldwin-based Framingham score. Every study has its own score. There's one behavior among them, and that's smoking, right? That's the obvious. Everything else is a biologic trait. Something I measure, I poke, I pinch, or something like that. That's what the risk factor. There are no, and they haven't made it into our armamentarium in order to prevent disease. So those folks who study the counting may not be all that happy with today's risk scores in terms of what they have contributed and what they have taken into practice. Insights based on decades of research on the origin and distribution of cardiovascular disease have also been channeled primarily into clinical settings, into individualized situations. This whole risk factor sort of paradigm for dealing with individualized situations. What is my person? Whether or not it's statistically correct to look at interesting populations with different approximation, but is it conceptual? It's important for a practitioner to be able to individualize it. But how have we used this information knowledge to identify the health and risk of populations? We have. More so, some of you were at the American Heart Association meeting a couple of weeks ago. There was a discussion about precision medicine, and I must say I was very surprised. We have once more sort of turned over the task of dealing with the health of the population to practitioners who have been trained to handle the individual encounters. So we were discussing what's the public health role of precision medicine. There is no such thing. But what these individuals were struggling with, and I do good medicine, I do prevention. It's something I do on a one-to-one basis. If we turn over the challenge of making the society healthy to individuals to do it one by one, we can be assured we'll never get there. So we have, unfortunately, channeled not only Evans County, but many of our studies into individual paradigms. Public health is the slow to address the social origins of health and disease. I think we have not moved the needle toward fixing societies, not individuals, and promoting health in societies and preventing disease in societies as opposed to individuals. And a wealth of information, I would say, from observational research is waiting to be put to the test of population-wide intervention. It doesn't happen. And if you look not only at but a long list of observational studies, we haven't taken to intervention. Interestingly, an anecdote I came across on Dr. Blackburn's website. A person who is never mentioned anywhere in the setting context of Gillings kind of framing the study, an office of NIH, what used to be called the Heart Institute, the National Heart Institute, was deputized to go to Framingham to examine whether Framingham was viable, whether a study should be conducted there, and came back with a glowing report saying, these guys know what they're doing. It's nice to have brought in these folks from Boston and into this setting of the Framingham of the community, which was then a more isolated community study. And the recommendation to the Heart Institute was, do an observational study. We need the numbers, we need a long-term follow-up, it should last 20 years. Fortunately, that was very excellent foresight. The other companion recommendations, do an intervention study right now. Start acting this on a population to find proof that intervening on these things actually qualifies health and disease. That, of course, was never done. Perhaps for good reasons. The information base wasn't there. You wouldn't think of large, complex and ethically challenging intervention. But ever since 1948, we're still waiting to do the other recommendation that this person came up with. Let's change this. Let's change the environment. Let's change the time. Anyway, I'll stop pontificating. I mentioned that that Dr. Heiss actually received the Genius Award in 1984, the Cardiovascular Award. The wording is very interesting. Commitment to the health of his patients, undoubtedly true. Insightful clinical observation, I'm sure that's true. Questions and resourcefulness. The guy never gave up. And he made us all do something remarkably useful in himself. So fortunately, he is a person who was isolated in a rural practice, studied the market, and hopes we need to do something. I should also mention that his heart was in family medicine and family care. He donated his funds, his award, to do that kind of research. And he has several resources I mentioned. It's worth looking at some of these very good materials contributed by several.
Yes, thank you very much for that great history. Many ideas come to my mind. Three things I want to say is that you mentioned we still use race 5 decades later on our. We also still use occupation, just like kind of sharecropping was probably, if they would have created a risk score back then, job class would have been probably #1 variable. We still use job class these days as a very crude estimate of advanced